All good. Good evening. How are you guys? You all good?
Good, thank you. How are you?
All right, thanks. Okay, so what I'm going to do this evening is to cover a bit of physiology and then clinical aspects of thyroid disorders. We can't concentrate on everything, so I want to give you a bit of an overview and just get you to think about thyroid function tests and some imaging so that when you see patients, you don't fall into the trap. The big problem with a lot of endocrine disorders is that if you don't see the free hormones and the pituitary hormones talking exactly to each other, then you really get into a trap and end up with the wrong diagnosis. So just to remind you, the thyroid gland, which is situated in front of the hyoid, thyroid, and cricoid cartilages, secretes T4 and T3, which will be converted mainly to T3 in the circulation, which is the active hormone. And when you ingest or take thyroxine, predominantly it's T4. You can give T3, but T4 has a half-life of 7 days, and so we tend to use T4 as replacement therapy, whereas T3 only has a half-life of about 20 to 30 minutes, and so you have to give it in multiple doses throughout the day, and it fluctuates too much. So if you give T4, the body will convert the T4 to T3, and this in turn will then feed back on the hypothalamus and pituitary via the thyroid hormone receptor, the beta receptor, and thereby regulate TSH secretion. So the pituitary TSH, the thyrotroph, will determine how much TSH to secrete to allow the thyroid hormone to function and secrete thyroid hormone. Now, why I've put this slide up is just to remind you that there are other things which cause TSH release. So TRH, which comes from the hypothalamus, will cause the release of TSH, and it can be inhibited by a hormone called somatostatin. And so the one switches on the thyrotroph, the other one will switch off the thyrotroph. And the only thing that can really inhibit the secretion of this pathway, if you want to get away from the thyroid hormone receptor beta, is the thyroid receptor alpha, and that's a drug called Triag. And we'll talk a little bit about that just now. So just briefly, I don't want to take you into too much detail, but this is the thyroid follicular cell. And so you have iodine, which you ingest, will get transported via the thyroid transporter into the follicular cell, and then it will undergo iodination to form T3 and it gets iodinated, and then it gets transported right into the thyroglobulin, into the colloid fluid, where it will bind to the thyroglobulin, which is the backbone. And so if you have one molecule of iodine which binds to monoiodotyrosine, 2 molecules is diiodotyrosine, 3 molecules is triiodotyrosine. So initially you get these single and double iodine molecules which binds to the phenylalanine molecule to form MIT and DIT, and that's coupled together to form T3 and T4. And once that's formed in the colloid fluid, it will undergo endocytosis, and then it will get transported back into the thyroid cell, where it will undergo, it will separate from the thyroglobulin and then secrete it into the circulation. So for this to happen, you have to have uptake of iodine, you have to have organification of iodine to the tyrosine molecule to form MIT and DIT, and then for it to be released, it has to undergo iodination, breaking off from the thyroglobulin and secreting. So the amount of thyroid hormone produced is directly dependent on the iodine molecules that you ingest, and that's why it's so important to have adequate iodine in pregnancy and in your diet to allow for adequate hormone synthesis. Now, this is all under the influence of TSH, which drives the thyroid hormone to do that. Now, we always think as T4 as the active hormone because we measure T4 and TSH, but it's the T3 pool, which is the active hormone, which will determine how your metabolism is performing. And so you want active T3 in the cell to be able to exhibit and allow the metabolic pathways to take place. And so the T3 gets transported into the nuclear cell via this thing called MCT8, and this can sometimes be deficient in genetic disorders. So in a euthyroid state, you have enough T3 that's transported into the cell, and you can see that T3 then will undergo its biological function by acting on the T3 receptor. And if you have problems with T3, for example, these are the deiodinase enzymes. So the T4 is broken down to T3 by this D1, and it will enter the cell. And in this situation, if you don't have D1, then the T3 and T4 will be circulating by itself. Now, the importance of these deiodinase enzymes are they regulate how much T3 and T4 is around the place. And so in non-thyroidal illnesses, which is the commonest cause of abnormal thyroid functions in the hospital setting, where you have decreased T3 due to decreased thyroid hormone secretion, and there's decreased conversion of T4 to T3 over here. So you have decreased T3 and inactivation of T4 and T3 to RT3. So when you want to measure thyroid function tests in an individual, you're measuring T3, T4, and TSH. But if you suspect that the T3 is being broken down, you need to measure RT3, because the RT3 will tell you that there's a problem with thyroid hormone metabolism. Now, the most important part of the whole talk is in this slide. This relationship between the T4 being secreted by the thyroid cell and the TSH being stimulated and secreted by the pituitary. And this is a log relationship. So for example, if the T4 is 10 and the TSH is high, it's 20. If you want to increase your T4 to 25, you'll do that by giving T4. It will then have a logarithmic inhibition, and the TSH will then get switched off to 0.1. So if you have someone who's underactive and they've got a high TSH, then their T4 is low, and if their TSH is suppressed in this range, then their T4 is high. So there's this logarithmic relationship, and this set point can change with certain conditions. So we always want to measure the TSH, but we want to know what the relationship is between the T4 and the TSH. So the most important thing to measure in someone that you're suspecting of having a thyroid disorder is to measure TSH. And so if the TSH is normal and the T4 is normal, can you see the T4 at the top of the screen up there? So yeah, you've got T4 at the top of the box, TSH on the left-hand side. So in a normal person, T4 is normal, TSH is normal. In someone who has hyperthyroidism, the TSH becomes suppressed. So it's low. And if the TSH is low and the T4 is normal, we call that subclinical hyperthyroidism. And if the TSH is suppressed and the FT4 is high, we call that classical primary hyperthyroidism. Now, in other conditions, you can have a high T4 with a high TSH, and that's not really hyperthyroidism. That's what we call hyperthyroxanemia. Or if the T4 is high and the TSH is normal. So these conditions over here, you want to know, are euthyroid hyperthyroidism versus true hyperthyroidism? On the other hand, if the TSH is high and the T4 is low, you have primary hypothyroidism. And if the TSH is, in this situation, high, but the T4 is normal, we call that subclinical hypothyroidism. And then you have the situation where the TSH can be normal and the T4 can be low, which is a sick euthyroid state. And if both the TSH is low and the T4 is low, that means that the thyroid is not being stimulated by the TSH. The problem is sitting up in the pituitary. You have secondary hypothyroidism. So we're going to talk about conditions where the TSH is low or normal, and the T4 is high. So primary hypothyroidism, that's a classical condition, a high T4, a low TSH. So what's the most common conditions that you find with that? So it means that the hypothyroidism is due to the thyroid hormone synthesizing and secreting too much thyroid hormone. And that needs to be differentiated from thyrotoxicosis, where there's excess circulating hormone, but it doesn't necessarily mean that the thyroid gland is producing the excess hormone. The thyroid gland may be destroyed. So in this situation, you have classical hyperthyroidism. So in this cartoon on the left, you can see a thyroid gland. You can see the TSH receptor. And so the TSH will bind to the thyroid, to its receptor, cause the thyroid gland to secrete T3 and T4, which will feed back on itself. Now, in Graves' disease, which we'll speak about, that TSH receptor is stimulated by a thyroid receptor antibody, and that's endogenously independent of TSH. It causes you to produce increased T3 and T4, which will feed back on the pituitary and switch off the TSH. And in a condition where you have nodules in the thyroid, where you have actually mutated TSH receptors, and the nodules undergo somatic change, so they produce endogenous T3 and T4 independent of TSH, and they will inhibit endogenous TSH secretion. So the classical causes of hyperthyroidism then is Graves' disease, which we'll talk about, nodular thyroid disease, such as a toxic adenoma, as I've shown you here, or multinodular goiter, iodine-induced disease, and then if the TSH is driving from the pituitary, stimulating the thyroid to produce hormone, or sometimes in pregnancy, and we're going to talk about trophoblastic disease and choriocarcinomas. Now, that's classical hyperthyroidism. So other causes of thyrotoxicosis is when you get destruction of the thyroid gland. So all that thyroid hormone that I showed you binding to the thyroglobulin within the thyroid cell is smashed and released into the circulation. And that can be caused by viruses, or it can be caused by drugs such as amiodarone. And then you have non-thyroidal causes of hyperthyroidism, such as factitious, where individuals are factitiously self-ingesting T3 and T4, so that increases the serum T3 and T4 and suppresses the TSH, or dermal tumors, which can produce T4, or really metastatic thyroid cancers. So let's talk about the commonest cause of hyperthyroidism, where you have increased thyroid hormone secretion. So as you can see here, the T3 and T4 starts increasing the secretion, and as that starts increasing and you get feedback inhibition on the pituitary, the TSH will start dropping. So in the early phases of the disease, you might have the TSH suppressed, but the T3 and T4 may be normal, and that's called subclinical hyperthyroidism. Once the TSH becomes suppressed and the T3 and T4 go out of the upper range of normal or elevated, you then have pure obvious hyperthyroidism or thyrotoxicosis. So Graves' disease is probably one of the commonest diseases of hyperthyroidism, more commonly occurring in females aged 20 to 40. 80% of patients with thyrotoxicosis will have Graves' disease. They present with the classical features of thyrotoxicosis. So one is that's related to the increased sympathoadrenergic system, stimulating the heart rate, tremors, sweating, palpitations, the effect of the thyroid hormone on the nervous system directly, and the effect of thyroid hormone on the peripheral nervous system. So the classical thyrotoxicosis, then the other features of the triad are thyroid orbitopathy, and the third feature of the triad is autoimmune spectrum. So yeah, you see this lady, she has a very prominent stare with her iris being clearly visible above her pupil, and this is called lag ophthalmos, or the thyroid stare. This is not thyroid orbitopathy. This is due to retraction of the upper eyelids due to the sympathadrenergic system. So this is one of the ways you can diagnose a hypothyroidism. You can also see she's got a goiter in her neck. And so patients with hypothyroidism or Graves' disease usually occurs over a 6 week to 3 month period and progresses. And the classical diagnosis is elevated T4, suppressed TSH, and they have positive peroxisomal and thyroglobulin antibodies, and they have a diffuse goiter. And to know that this goiter is driving the hypothyroidism, you can do a radioactive iodine scan, which looks at the uptake of iodine or uptake of technetium. So nuclear medicine technetium scan shows diffuse tracer uptake. And if you did an ultrasound, this is a very hypervascular gland. And so in a young individual with biochemical hypothyroidism and a gland with increased tracer uptake, the diagnosis is Graves' disease. And the treatment is to initially, in all cases, to give anti-thyroid drugs. And then if patients relapse or they prefer, or if they're elderly, to give radioactive iodine. Thyroidectomy in Graves' disease is really reserved for individuals who have big goiters that don't respond well to treatment, or if it's a patient's preference. So just showing you some of the clinical features of thyroid disease. Here again is the thyroid stare, but one of the most prominent features is the neurological effects of thyroid hormone excess. The marked wasting, the weight loss, the proximal myopathy. If you get them to squat, they have marked weakness in their thigh muscles or weakness in their pelvic girdle, so that you put their arms up and you get them to push upwards, you can overcome that. And you can see the marked wasting in the neck muscles. And in very severe forms of the disease, you can have paralysis, you can have seizures, you can have cranial nerve abnormalities. So the neurological features are very important. And we'll talk a little bit about the other features in a while. This is the nails of somebody with Graves' disease, where the nail bed is broken up. They have onycholysis. And then the other features of autoimmune disease, where the proteoglycans get affected. You can see the pretibial myxedema in the anterior tibial, which is often inflamed, and it's edematous-like, but it's not pitting edema. And then the other features is you can get big, swollen and edematous-like looking fingers, toes, which is the thyroid acropathy. So those are some of the features, skin features of hypothyroidism. Now, if you look at the patients with hypothyroidism, you can see the symptoms will differ according to their age. So young people often present with florid hypothyroidism, with weight loss in 85%, palpitations, weakness and agitation, nervousness, heat intolerance. Those are the classical features that young girls or men present with hypothyroidism, such as Graves' disease. Whereas elderly people in their 80s tend to have a more apathetic form of thyrotoxicosis. Again, they can have unexplained weight loss, they can have palpitations because of fibrillation, they can have this marked weakness, they can't cope, they can't get out of bed, and dizziness. But not to forget, they can have memory loss and tremors in elderly people, and they're often misdiagnosed as having neurological conditions, and then they can have local symptoms. Individuals in their 60s to 80 have a mixture of symptoms. Now, if you look at the signs of hypothyroidism, again, according to the ages, you see different features. So in young people, they have this rapid tachycardia, the tremor, the eye, I mentioned the lid lag, the fine skin, and in men, it's not unusual sometimes to have gynecomastia because they have increased relative estrogen levels. And then the classical features, when you palpate their neck, as I showed you in the previous lady, they have a diffuse goiter. So this is the classical Graves' disease in a young person. In an elderly person, you tend to have a different type of the disease. You tend to have more things presenting like atrial fibrillation or unexplained heart failure or unexplained tremors. And again, they can have a diffuse goiter, but often they can have a nodular disease. So Graves' disease, the classical sympathadrenergic symptom type of disease, is in young people, whereas in elderly people, it presents as apathetic thyrotoxicosis. And again, just to remind you, rare things like gynecomastia, don't forget about Graves' disease. Now, the treatment of this disorder is to inhibit thyroid hormone synthesis. And as I explained to you earlier, you want to inhibit iodine trapping by the gland. So you can use drugs like the thionamides or methimazole, carbimazole, neomercazole, or propylthiouracil, and they inhibit the trapping of the iodine and the iodination of the binding of the T3 and T4. Other drugs such as iodide and lithium inhibits the release of thyroxine. So the side effects of antithyroid drugs, such as carbimazole or neomercazole or propylthiouracil, are very important. They're drugs that are commonly used, and the most common ones are skin rashes. Hepatic necrosis is very, very rare, but is thought to occur more with propylthiouracil. Neutropenias are common, but if you ask patients to look at what are the main features to look out with side effects, you tell them to look out if they got a skin rash, if they get a tonsillitis or a sore throat, you check for neutropenia, and if they get very painful joint disease, they can often get propylthiouracil-induced C-ankle polyarthropathy. And then in pregnancy, you tend to use drugs like PTU because there are teratogenic effects such as prune belly and the abdominal wall not fusing properly in individuals. Now, the Graves' eye disease is actually not a pleasant disease to have, but is part of the Graves' spectrum. But what's important is that the thyroid eye disease does not always go in parallel with the thyroid secretion. In other words, you can have people who have normal thyroid status and have severe thyroid eye disease. You can even have people with hypothyroidism, Hashimoto's, having thyroid eye disease. And this is the infiltration of the lymphocytes and inflammatory tissue into the extraocular muscles, as you can see here on a CT scan. This is the medial rectus. You can see how thick they are. They're greater than 2 millimeters. And in coronal section, you can see the thickened ocular, extraocular muscles over here. And so they interfere with the movement of the eye. So if you get people with funny eyes that are not converging and moving in synchronous range, you need to always think of thyroid eye disease, and especially in individuals with Graves'. Now, the important facts about thyroid orbitopathy, as I said, it can occur in both hyper and hypothyroidism. It occurs much more commonly in women, approximately 40% of Graves' disease. It can last quite a long time, 2 to 3 years, although it often appears as a unilateral proptosis. Bilateral disease is most common, and things that really aggravate the thyroid orbitopathy that you need to know is hypothyroidism, radioactive iodine, and smoking. So these are things, if the patient's a smoker or has been treated, is going to receive radioactive iodine, you need to be very careful that you don't cause an orbitopathy. There's different ways of grading the orbitopathy according to if there's just soft tissue involvement, proptosis, corneal involvement, or sight loss. And one of the ways to measure the activity of the Graves' orbitopathy is to measure the thyroid receptor antibodies, which correlates well with them. And the treatment can be simple treatment from ocular lubricants to corticosteroids, more potent immunosuppressives, orbital decompression, radiation therapy, and recently monoclonal antibodies. So we've spoken about Graves' disease, which is an autoimmune disease which stimulates the thyroid cell via the thyroid receptor to become overactive, and its first cousin is Hashimoto's thyroiditis, and a number of individuals with Hashimoto's disease can present initially with a short phase of hypothyroidism. However, this condition is totally different to Graves' disease, whereas in Graves' disease you have a very vascular, heterogeneous thyroid gland. In these cases, on ultrasound, you have these confluent hypoechoic nodules, which are vascular. You have large infiltrates of lymphocytes, and these patients end up having hypothyroidism. So they present with an elevated TSH and a low T4, and they have positive anti-thyroglobulin antibodies. And you can see this individual over here, which is profoundly hypothyroid with periorbital edema, swollen faces, dry skin. And once you treat them with thyroxine, they completely normalize. But just to remember that you don't get caught out, because sometimes Graves' disease can present with florid hypothyroidism, but sometimes this condition, Hashimoto's, toxic Hashimoto's, has a short phase of hypothyroidism. And when you give individuals anti-thyroid drugs and they've got this form of autoimmune disease, they'll become rapidly hypothyroid, whereas Graves' disease, it takes at least 4 to 12 weeks to develop a euthyroid status. Now, the other common causes of having an overactive thyroid, often just a suppressed TSH, is autonomous functioning thyroid nodule. So this is very common in elderly people or in private practice, where people have thyroid function tests done, and the only thing you find is a suppressed serum TSH. So in this individual, could be subclinical, where the TSH is suppressed and the T3 and T4 is in the normal range, until such stage that the nodule gets big enough and the T3 increases and eventually the T4 increases. And these individuals present with atrial fibrillation, commonly, or heart failure, or they can present with obstructing signs. So you can see here is a big thyroid nodule, which causes deviation of the trachea to the left. And if the nodule gets bigger and starts growing retrosternally, it will put pressure onto the jugular venous pressure, so you can get a positive Pemberton sign, where the face becomes engorged when you ask the individual to raise the arms into the air, and it presses on the jugular venous system, and you get congestion in the face, and the face becomes plethoric. So in these individuals, suppressed TSH, normal T4, make sure they haven't been exposed to iodine or radioiodine contrast. You can then do a nuclear medicine scan, and there you will see a single thyroid nodule with suppression of the contralateral thyroid gland, and that is called an autonomous functioning thyroid nodule. On ultrasound, it's a solid nodule. Very rarely are they malignant. 90% of them are plus are follicular adenomas, and the treatment of this condition is very simple. If they're under 3 centimeters, you can give them a capsule of radioactive iodine, which is taken up into the gland and destroys the gland. Or if they're larger, you often have to then do a hemithyroidectomy. Now, that's single nodular disease. This is multinodular disease. And these are individuals who've been often in Africa, South America, where they become mist, and these individuals get multiple nodules. As you can see in this cartoon in the bottom, they start getting daughter nodules, and as the nodules increase in number, you start getting increase in thyroid hormone secretion with TSH suppression, and eventually the TSH is totally suppressed, and then the T3 and the T4 goes up. And again, in these individuals, they present again more commonly in women. Often they have multiple nodules that you can feel, but sometimes individuals with a short stubby neck, you can't feel it. So you need to percuss their manubrium and see if there's dullness over the manubrium. And they present with either obstructive symptoms such as a retrosternal goiter, or they can present with a single thyroid nodule, or classically with apathetic thyrotoxicosis, as I mentioned earlier and showed you in that slide with the symptoms and signs, where they have atrial fibrillation, unexplained heart failure, or unexplained weight loss. And you can see if you do a nuclear scan, you'll see multiple hyper and hypo functioning nodules. And again, when the TSH is suppressed in this condition, malignancy is very, very rare. These are classical multinodular thyroid disorders. So here's an individual, as I mentioned earlier, with a large retrosternal goiter, as shown on the coronal section of the CT scan and the cross-sectional section. Here's the trachea, which is compressed and pushed over to the left. There's the vertebra, so the trachea is pushed right over and is compressed. And when this lady raises her hands, it blocks off the venous system, and you can see she becomes very plethoric and suffused in her face. And so these individuals with retrosternal goiters, again, more commonly elderly women, can present with dysphagia, dysphonia, their voice is weak or hoarse. Occasionally, they may have none of those features. They can present with a large cervical gland. Often these retrosternal goiters are euthyroid or with a mildly suppressed CMTSH. And the most important findings are the large mass with a deviation of the trachea. And it just shows you that the majority of these cases are either multinodular goiters or follicular adenomas in 90%. Occasionally, Hashimoto's can be large, and very rarely papillary thyroid carcinoma. So we've spoken about the common causes of thyroid disorders, such as Graves' and multinodular goiter, where you have hypothyroidism due to increased thyroid hormone synthesis and release by the thyroid gland. Now, thyrotoxicosis, on the other hand, is when you get destruction of the thyroid gland. And one of the commonest causes for destruction of the thyroid gland, here you can see an ultrasound showing necrotic nodules, is de Quervain or viral thyroiditis. Now, viral thyroiditis classically occurs either just in early spring or in autumn, and these individuals are 20 to 50 years of age and can present with severe pain over their thyroid area, or occasionally radiating into the ear. They have a flu-like illness. They have an initial phase of thyrotoxicosis, so they're agitated with high temperatures, and then they progress into a hypothyroid phase. And usually the thyrotoxic phase is about 6 weeks, and the hypothyroid phase is about 6 months. 20% of these individuals relapse and 90% recover. So again, you've got to be aware of this diagnosis, tenderness over the thyroid, a very high ESR with leukocytosis. I mentioned the triphasic TFTs, and the way you make that diagnosis is either an ultrasound to look at these necrotic changes. If you biopsy them, you see these granulomatous thyroiditis, or the other way is to do a radionuclear iodine scan or technetium thyroid scan, and you can see what happens in these individuals. Because the gland is being destroyed, there is no uptake of radioactive activity in the thyroid gland. So the majority are painful thyroiditis. However, 5 to 10% can be painless thyroiditis. Now, the painless thyroiditis cases are the tricky ones, because these individuals really don't have much to show. They don't have a palpable goiter often. They don't look thyrotoxic, and all that happens is they gradually deteriorate and lose weight, and they sometimes have diarrhea, and they're often thought of having underlying cancer or underlying tuberculosis or autoimmune disease, and they're often missed. And unless you do the TSH to show that they're actually or thyrotoxic with a suppressed TSH and a high ESR, the high ESR often sends them into the realms of the oncologist and the hematologist, thinking that their weight loss is due to malignancy. But when you do the TSH, you find the TSH is suppressed, and then when you do the scan and you show the decreased uptake of the gland, you've made the diagnosis. And often in these individuals, they may require a short course of corticosteroids, and they completely recover, they gain weight, and instead of thinking that they're dying of cancer, they get completely better. And so it's a very gratifying condition to treat, especially if they've got pain. Their pain will subside within 48 hours of commencing a prednisone. So important condition. Now, the other one which mimics that is individuals who get their thyroids get destroyed by amiodarone. So you know that amiodarone is a drug which is commonly used by the cardiologist to treat atrial fibrillation. And so amiodarone is an iodine-rich compound, very similar to thyroxine. It's 37% by weight, and so 8 to 17% of the iodine is released. And the problem with amiodarone is that it binds and it stays around for 50 to 100 days. So these individuals become loaded with a lot of iodine due to the amiodarone, and they can stay in the stores for up to 9 months. And so depending what happens to the thyroid gland, this can then damage their thyroid gland or be stored in their thyroid gland. And so thyroid abnormalities and very catastrophic abnormalities can occur in about 20% of individuals treated with amiodarone. So this is a case of somebody, a 49-year-old woman, who presented with atrial fibrillation. She was commenced on amiodarone in 1997, and she then started to present with tremors, agitation, and weight loss. And you can see this was in 1997, and 2 years later, she presents with symptomatic disease. So she's been loaded with amiodarone all the time, and initially her only symptoms are, tremors, agitation, and she's found to have a suppressed TSH but a normal FT4, until eventually the amiodarone causes more damage and the T4 starts going up. And one way, as I said, to make the diagnosis, you can measure the urinary iodine, and again, you do a nuclear medicine scan and you see it's a negative scan. Now, the reason that amiodarone causes this condition is that there are two types of pathophysiological changes that occur with amiodarone. You can either have, on the one hand, where the amiodarone is stored in a multinodular goiter, so the goiter acts as a factory, and the storage stays there for ages and just slowly is released. And so on ultrasound, you'll find a very nodular and enlarged gland. On the other hand, in type 2, the amiodarone actually causes an inflammatory change and destroys the thyrocytes, and you get this destructive thyroiditis, where you get increased inflammatory markers such as IL-6, again, the radioactive iodine or nuclear medicine scans are negative. And these two pathophysiological conditions causes the thyroid to be either destroyed or to produce huge amounts of thyroid hormone, which can make individuals very sick. In fact, they already have cardiac disease such as fibrillation or ventricular tachycardia. That's why they're given amiodarone in the first place. And so they can die from their cardiac disease. And because the amiodarone stays around for so long, 6 to 9 months, that if they haven't got a strong heart, they are going to die from the amiodarone-induced thyroid disease. And so treatment is very aggressive. You can use anti-thyroid drugs. You can try and bind the thyroid hormone in the bile salts by giving cholestyramine, but you sometimes have to be very aggressive, give them high doses of corticosteroids. You sometimes have to plasma freeze them or do an urgent thyroidectomy. So it can be quite a devastating disease. So the message is amiodarone and thyroid don't go well together. If you've got someone either with an overactive thyroid, go into the history or looking for amiodarone, or if the patient has been given amiodarone for a cardiac disorder, monitor him very carefully with regular TFTs, and for a long period of time, as you saw in this lady, for 2 to 3 years, the amiodarone can hang around. Now, the third condition with hyperthyroidism, we've spoken about primary conditions, that is the thyroid gland itself being abnormal and either releasing thyroid hormone due to increased secretion or being destroyed by the viral thyroiditis or amiodarone disease. And so the next condition I want to talk about is secondary hyperthyroidism. That is a condition where the pituitary is driving the thyroid. So when you get someone with a high TSH, don't think automatically they've got hypothyroidism. Look at the T4. And if the T4 is high, then you need to think a bit carefully. Now, if the T4 is high, don't think automatically, hey, they got a thyroid disease, because if they were primary hypothyroidism, the TSH would be suppressed. But if they've got secondary hypothyroidism, the TSH is high or even normal. So this is patients with TSH secreting pituitary tumors. And the sad thing is that these patients are often misdiagnosed as having Graves' disease or hypothyroidism, and their delay for diagnosis is late. So the TSH, because it's high, does give you some goiter signs. And so these people undergo surgery or radioactive iodine, and then years later, they found to have these large pituitary tumors which have been missed. And because they're large, they have hypopituitarism. And the diagnosis is made by, as I mentioned before, a high FT4 and a high TSH. And if this TSH is made up of an alpha and a beta subunit, so once the TSH is high in the presence of a high FT4, you measure the alpha TSH subunit, and that gives you the diagnosis. And then you can do a scan of the pituitary and have a look. So this is an example of somebody, this is a 24-year-old woman presenting, which was thought to have Graves' disease because she had a high FT4. You can see over here in 1992, the FT4 was 29, and the TSH was in the upper range of normal, 2.9. So someone thought, oh, well, she's got classical Graves' disease, she's got a diffuse goiter, and she was submitted for thyroidectomy in 92. In 96, she presents with recurrent hypothyroidism. So after surgery, the T4 went back into the normal range and the TSH was in the normal range. But then all of a sudden, the T4 started going up and the TSH was even higher. So this confused the physician, thinking, what is going on here? Why is the TSH going up? She, in fact, gets pregnant, and you can see that there's even further increases in her T4. And eventually, someone makes the diagnosis in 2001 that she could have a TSH secreting pituitary tumor. And you see this very large macroadenoma, which has destroyed the normal pituitary. Here you can see the macroadenoma causing compression of the optic chiasm. And so this patient was investigated, had an alpha subunit, which you can see was very high, normal being less than 0.5 was 27, and the patient underwent surgery and still had persistent hyperthyroidism and a high TSH, and then was put onto sandostatin. And you remember the very first slide I showed you that the control of TSH is by TRH, which stimulates it, or by somatostatin, which inhibits it. So in this condition, the somatostatin analog, long-acting sandostatin, is used, which inhibits TSH production. Okay, so let's move on then to the next lot of conditions where the T4 is high, but the TSH is normal. So the previous case could have had a normal TSH, but in this condition, we call it euthyroid hypothyroxemia. So the TSH is normal. So based on the TSH is euthyroid, but the T4 is high, so we call that hyperthyroxemia. And so what are the causes of a high T4 in the presence of a normal TSH? Well, the T4 is normally bound in circulation by binding globulins, thyroid binding globulin and albumin, and there is free T4 as well. So in the old assays where we measured total T4, if you had abnormalities in binding globulins, such as myeloma or abnormalities in albumin, then the TBG would have been increased and you would have had a falsely elevated T4, which is called euthyroid hyperthyroxemia. Occasionally in the assays, you can have heterophile antibodies which interfere with the assay and give you a falsely high T4 or T3. And in that situation, you have to ask the laboratory to run a special test where they run the serum over a PEG column and the antibodies bind to the PEG column, and you can measure the true free T3 and T4. So if you're suspecting that there could be a technical problem, you speak to the laboratory and ask them to exclude antibodies. So there's these other conditions then which can result in euthyroid hyperthyroxemia, and one is thyroid hormone resistance, the other is acute psychiatric illness, and the final one is hyperemesis. So let's go through that and I'll just show you a little bit. So thyroid hormone resistance syndrome is very rare. And I don't want to spend a lot of time on that, but I just want to show you a little bit about this condition. Because again, they are misdiagnosed. Here's a 38-year-old woman. She presented with a goiter, was treated with radioactive iodine, and was thought to have classical hypothyroidism. But here, as you see, the FT4 is high, 36, and the TSH is in the normal range. And in this case, there was a problem with the T3 receptor. The T3 was not switching off TSH production. So this is T3 beta receptor disease, which is an inherited disease. And these individuals present with certain gene abnormalities, and the degree of thyroid hormone resistance can be global, so it can be all over, both at the pituitary level and at the peripheral level, or it can be only in the periphery. And so the only message that I want to give you here again is when the T4 and the T3 are high and the TSH is normal, you've got to think of other conditions. And this is a condition of thyroid hormone resistance. They have specific gene abnormalities, and in children, they can present with certain congenital abnormalities and intellectual impairment, facial abnormalities, etc. The last case that I want to discuss with you is probably one of the commonest endocrine conditions seen in gestational medicine, in pregnancy. That is hyperemesis gravidarum. So when people think of hyperemesis gravidarum, they think of a woman who's pregnant, is vomiting and vomiting, and that's all that happens. But in fact, what happens is the beta-HCG, which causes the relaxation of the smooth muscle and the vomiting, has very other serious effects on the thyroid hormone system. And these individuals are often misdiagnosed. They present in their first trimester commonly with a lot of vomiting, and they have biochemical thyrotoxicosis. So here you see a lady who's 32 years of age presenting with nausea and vomiting. She's got a very high beta-HCG, and you see that at 10 weeks of pregnancy, she has a high T4 and a suppressed TSH, and towards the second and third trimester, that normalizes. So this just shows you what actually is happening. Here is the normal situation where the pituitary produces TSH, which binds to the receptor on the thyroid cell and produces T3 and T4, which will feed back on the pituitary gland. During pregnancy, once the corpus callosum undergoes atrophy and starts forming the placenta, the syncytiotrophoblasts produce excess of beta-HCG, and beta-HCG has 80% homology with the serum TSH. So the TSH receptor on the thyroid cell gets stimulated by the beta-HCG. So if the beta-HCG is going to stimulate the thyroid, you're going to get hypothyroidism with an elevated, with a high T3 and T4 and suppression of the TSH. So it looks like classical primary hypothyroidism, but the thyroid gland is in fact normal. There's nothing wrong with the thyroid gland. What's happening is that the beta-HCG is stimulating it. And if you look at the bottom over here, you can see the prevalence of hypothyroidism, that is suppressed serum TSH or mildly suppressed serum TSH in the first trimester, occurring in about 20%, but it can hang out to the second trimester, even the third trimester. If you look in the cartoon on the far right, you see gestation. You see in the dotted line the beta-HCG secretion going up in the first trimester and then coming down once the fetus is formed. You don't need beta-HCG anymore because the placenta doesn't need to produce it, and the very high levels drop off. And so you see the TSH being suppressed because of the beta-HCG, and then as the beta-HCG drops off, the TSH goes into the normal range, and while the TSH is suppressed, the T4 goes up. Now, just to remind you that this is normal. Hyperemesis gravidarum is a normal condition. However, it's an exaggerated disease that can occur in pregnancy and make women very, very sick, and they can lose weight. If you have tumors of the corpus callosum, that is trophoblastic disease, the hydatidiform mole or choriocarcinoma, these individuals can have profound and severe hypothyroidism. And you know, they can be misdiagnosed and sent for surgery. And once you treat the underlying condition, which is the beta HCG and the hydatidiform mole, once they undergo a DNC or surgical removal, then this condition goes completely back to normal. So I'm going to end off on my last slide, which is the thyroid storm. And thyroid storm is a catastrophic condition where you have just excess amounts of thyroid hormone being produced. And it often occurs in Graves' disease, sometimes with nodular disease, but may be precipitated by a severe underlying illness or by an anesthesia. And so what happens in these individuals, they can have very high thyroid hormone levels. Temperatures can go into the very high 38 degrees, 39, 40 degrees. They can get hypothermia. They develop tachycardias with atrial fibrillation, resulting in heart failure. They can have liver problems with jaundice, can have diarrhea, central nervous system agitation, delirium, seizures, and there's a precipitating event. And so when people with severe hypothyroidism are unwell, you can actually score the severity of their disease and work out if they got a thyroid storm. And then these individuals, if their scores are high, need to be treated very aggressively with beta blockers. They need to be cooled, they need to be given steroids, and they need to have active anti-thyroid medications. So I'm going to end off by just saying that I hope I've given you some insight, at least clinical insight, that thyroid function tests must always be interpreted with respect to the clinical scenario. You need to look at the patient, think about the patient, and think about the thyroid functions. You must remember that there's always a close but inverse relationship between the T4 and TSH, which is log linear. That is, the higher the T4, the lower the TSH. If there's any deviation from this type relationship, where the TSH is either abnormally high or normal for the T4, or the reverse in hypothyroidism, then other investigations are indicated. Thank you very much, and I'm happy to take some questions.
Thank you very much, Professor Diamond, for another wonderful presentation. Do the students have some questions or comments?
I have a couple.
Hannah,
Always
go
a
ahead.
pleasure.
I was gonna first, one of them was just a comment. So basically, when you were commenting about T4 and TSH, you're basically talking about the axis, isn't it? So because you generally have that negative feedback loop, and then if you have something that is stopping the TSH from affecting the, for example, the thyroid, if you have still say, for example, elevated T4, but then you have a normal TSH, that tells you that there's something in the thyroid itself, because it continues to release and that negative feedback is not dropping the TSH level. Is that correct to say that?
Yeah. There's something else going on. Normally in the thyroid, but there, as I showed you, there can be other conditions which give you false interpretation. But the point you're making is the red light is flashing. It's not talking sense.
Okay. And in Graves' disease, for example, do we scan those patients? Like,
yes. So if you've got someone with Graves' disease who, even if it's classical Graves' disease where their eyes are popping out and they're tremulous or whatever, you should always do a nuclear medicine scan to confirm that it is the thyroid that's overactive, that it's diffuse, and also to make sure there isn't a little hidden cancer in the thyroid.
okay.
But what the beauty of it is you've got a high T4 and a suppressed TSH. You've got to make sure that that's not a viral thyroiditis or something else that's doing it. Obviously, if the clinical presentation looks classical with poppy eyes and whatever, you often think you don't, but it's a good idea to make a proper diagnosis. Even if you did the thyroid antibodies and the thyroid antibodies were positive, you should still do a scan, either a nuclear scan or an ultrasound.
Okay. My last question. the decurvin thyroid.
Thyroiditis, yeah.
I find that obviously because you said they're coming with like a earthy and viral type symptoms. Generally, how do you because it is an exclusion, like a diagnosis of an exclusion. So if nothing else, potentially could be this. But you commented on something like ESR being high. So is that the biggest point that you will see in your blood test? Because generally you'll have high levels of all white cells and all that. So if you have any
Exactly. So you've got somebody with high levels of white cells and you've got a high ESR. The patient could have tonsillitis for all you know, right? You've got to have that increased awareness because these patients aren't going to look at you classically thyrotoxic. They're not going to be tremulous and shaking. They've got a very apathetic thing. You know, if they've got severe pain over the thyroid or going into the ear, that highlights that, you know, that's a de Quervain disease. But sometimes they can be painless. So what you've got is somebody with a high ESR and a high white cell count, and you think, oh, well, I can't find anything. I'm going to send them to the oncologist. Or if they got pain in the neck, you think, oh, maybe they got tonsillitis, and you look in the back of their throat and their throat's a bit red. But you've got to be sure there's tonsillitis. You know, if there's no pus on their tonsils, that's not tonsillitis. And they have very high ESRs. The ESRs are 50, 60, 80, 90. So once that happens and there's weight loss or something funny, do a thyroid function just to be sure you're not caught out.
Thank you. I appreciate it. Thank you.
Terry, there was a presentation on the weekend by Junaid, who I see is one of the students on today, who highlighted the value of a junior medical person taking the time to look at the history and the results. And I think the case that you presented about the pituitary adenoma was a case in point that had somebody taken a little bit more time to do a little bit more thinking through the result, the problem wouldn't have been noticed so late in the history. Would you concur with that view?
Yeah, I think, you know, the beauty is that you always, if the clinical signs are not fitting with the biochemistry, you need to think again. But people tend not to examine patients and they look at the biochemistry and then they think, oh yeah, the T4 is high, they're hypothyroid, and they jump into the thing. So definitely the story is very, very important. But the thing in endocrinology is that you can fall into the pit because you think the tests are telling you what you want to know, but it's not. You've got to make sure that they're talking to each other, the free hormones and the pituitary hormones. Otherwise, you will misdiagnose the case.
Right. If there are no other questions, I think we should thank Professor Diamond yet again for a marvellous presentation. And the next in 2 weeks, I believe, is by Professor Garriman on pituitary disease. So thanks, everyone, and good night.
Professor Dewan, sorry, could I ask a quick question, if that's okay?
Yes, no, fine.
Thank you. Professor Diamond, thank you so much for the presentation tonight. I just had a quick question. When you were talking about the amiodarone-induced thyrotoxicosis, is the main sort of process that you would monitor with the thyroid function test just to ensure that we don't go towards that condition? Is that right? It's monitoring.
Yes, so amiodarone can actually spin it both ways. It can cause this hypothyroidism which just grumbles away, and as I mentioned, these people already have, you know, heart problems, and you don't get this overwhelming, you know, features of hypothyroidism with the tremors and the agitation or whatever. All they're getting weaker and weaker in front of your eyes. So the actual severity of the thyrotoxicosis is out of keeping with the disease, because these people don't get T4s in the hundreds or, you know, 90s like Graves' disease. They get T4s in the 30s and 40s, and you think, oh, you know, or the TSH is suppressed, and you think, oh, that doesn't look that bad. But meanwhile, they're losing weight, they're becoming myopathic. So in the face of amiodarone, any abnormal thyroid function, suppressed TSH needs to be monitored carefully, but the patient needs to be examined, because the patient is getting worse and worse. And the problem is they often present to us by the time they're in heart failure, and by then they've already got a cardiomyopathy, and you have to then, you know, rush in and take out their thyroids and whatever, and the mortality is high. So you need to monitor anyone on amiodarone. the majority of them will get this TSH abnormality if they've been on amiodarone for a long time. About 70% will get hypothyroidism, but about 30% will get hypothyroidism. So the TSH will go up in hypothyroidism. So again, the lesson for you tonight is, in the face of amiodarone, measure the TSH and keep measuring it if they've been on it for a long time, up to 2 years.
All right. Thank you very much again, and good night to you all.
Thank you, Professor Diamond. Thank you.
Thank you very much. Bye.